So now we are done with non-Mendelian disorders. Let's see about chromosomal disorders. So chromosomal disorders could either be a numerical disorder or a structural defect. So in structural defect, it is going to be a numerical disorder is going to be either an autosomal disorder, autosomal chromosomes are going to be affected, or sex chromosomal disorder. Okay. So first we'll see about the structural disorder. Okay. Structural disorder as in something related to the arrangement or the structure of the chromosome is going to be affected. So first one will be a deletion. A chromosome is going to be deleted. So examples of this will be VHL syndrome, which is von Hippel-Lindau syndrome. Here the deletion is going to occur in chromosome 3p. Then Cre-Du-Chat syndrome. So we have many syndromes which are associated with deletion. I'm just taking few examples. Cre-Du-Chat syndrome is going to be partial deletion 5p. Okay. Cre-Du-Chat meaning, it actually means cry like a cat. Cry like a cat is called. So in this thing, the child is going to cry like a cat. So that is why this name of Cre-Du-Chat has been given. So in this, partial deletion of 5p is going to be there. So the second structural defect will be a inversion. Inversion in the sense, there are two chromosomes. So from one chromosome to another, it is going to have a inverted sequence. So suppose in this chromosome, this part, this orange part is there and this violet part is there. So if it happens on the same side of the chromosome, so this is the same arm of it, but just this violet had come this side and the orange had gone this side. So the sequence has just reversed like this. So this is called as paracentric inversion if it is happening on the same arm of the chromosome. And it is called as pericentric inversion if it is happening on opposite arms of the chromosome. So from the short arm, it has moved on to the long arm. So mutually they have exchanged their content between the short and the long arm. So this is called as pericentric inversion. So the example of inversions will be, usually you see it in acute myeloid leukemias. So example is inverse 16. Inverse 16 is going to be associated with AML M4, a specific type called as AML M4 EO actually. So in this type, they'll have lots of eosinophils. So inverse 16 is one of the acute leukemias wherein you don't need to have 20% blast count to call it as an acute leukemia. Just like that, if you see an inverse 16, you can call it as an acute leukemia, even though the blast count is less than 20%. Okay. So apart from that, there are two other things which can be called as acute leukemia, even though the blast count is less than 20%, which are genetic aberrations like translocation 15-17 associated with AML M3. Acute promyelocytic leukemia, right? Another thing is 1821. So the 821, sorry. So all these three are going to be associated with acute myeloid leukemia, even though the blast count is going to be less than 20%. So that we'll be seeing again in leukemia. So just remember, inversion is again classified into paracentric or pericentric based on the part in which the inversion takes place. Okay. The next thing is a ring chromosome. Ring chromosome happens when the ends of a chromosome are going to be broken. So when the ends are broken, the ends become sticky. So when they become sticky, they tend to attach to themselves like a ring. So they form a ring like this. The attached sticky ends form a ring like this, and that is going to lead to problems again. So the best example is Turner syndrome, wherein we have one of the Turner syndrome, we normally know it is 45XO. So here actually the X was deleted, right? But there is some other pathogenesis also, which is 46X ring chromosome. So here there is no deletion, but there are 46 chromosomes. So one of the X chromosomes is normal, but the other chromosome is actually a ring chromosome like this. So this ring is of no use actually. Basically, it is like a null phenotype only. So in that case, this X is void. So it is basically like an X0 only, but we represent it as 46XRX. Okay. So this is another genotype of Turner's syndrome. Then we have isochromosome. Isochromosome is one in which there is going to be a transverse plane of division. So the normal plane of division is going to be longitudinal like this. So that you are going to have two pairs of chromosome like this, right? But in isochromosome, the division is going to happen transversely. So transverse plane of division is going to be there, which is going to result in these two are going to form a single chromosome like this, and these two are going to form the another part of the chromosome, which is the long. So it is going to basically result in one chromosome having both short arms and another chromosome having both long arms. So this is like 2p and this is going to be like 2q. Okay, and this 2p is going to be of no use, it is going to be lost. And as such, this smaller chromosome is not going to have much of the genetic material, so its loss is not going to cause much of a problem except in certain conditions. Okay, so only this long chromosome is going to be present. So the question can be like this: so what is the cause of isochromosome? It is due to a transverse plane of division, that is meaning it is perpendicular to the normal plane of division. So the normal plane of division was longitudinal, right? So transverse means it is perpendicular to the normal plane of division. So the examples of isochromosomes are isochrome XQ. This is the most common isochromosome which we see. And if you there is isochrome 17q. This is the most common isochromosome which is going to be associated with cancers. Okay, then we have isochrome 12p. This is the most common isochrome which is going to be associated with testicular tumors. Okay, so isochrome 12p for testicular tumors, isochrome 17q for cancers, and then isochrome XQ is the most common isochromosome, sorry. Then we have translocation. So under translocation, it literally means there is going to be rearrangement between the chromosomes. So in that we are going to have balanced translocation and Robertsonian translocation. So balanced translocation is one in which there is going to be exchange of genetic material between two chromosomes, but the exchange is going to be equal. Then there is no going to be any loss of genetic material. Okay, so from one chromosome, the genetic material is going to be transferred to the other chromosome, and that chromosome is again give back its own genetic material to this chromosome. So there is going to be equal distribution between these two chromosomes. The best example of this is going to be chronic myeloid leukemia, in which the characteristic translocation is translocation 922. Okay, so here it is going to result in the fusion of BCR ABL. So ABL is actually present in chromosome 9, while BCR is going to be present in chromosome 22. So suppose if we take this as chromosome 9 and this as chromosome 22. So suppose this is the chromosome 9 here and chromosome 22, and here there was ABL which was present at this side, and BCR is going to be present in chromosome 22 over here. So in this translocation, this ABL, this part of the chromosome is going to be shifted to this part, and this part is going to come to this chromosome. So this shift has happened. So actually what happened is this ABL is going to come near the BCR. So ABL has come into a translocated into a site near to the BCR gene, and this fusion is going to result in increased tyrosine kinase activity, which is the major pathogenesis for CML. Okay. So this chromosome 22, in which we are going to have the fusion of this BCR and ABL, is going to be called as the Philadelphia chromosome. So Philadelphia chromosome is chromosome 22, in which BCR ABL fusion is seen. Okay, as such there is going to be genetic material transfer, but ABL has come to a position near the BCR on chromosome 22. So this is balanced reciprocal translocation. Then we have Robertsonian translocation. So Robertsonian translocation happens in acrocentric chromosome. So what was acrocentric? Yes, it is the centromere's location is going to be near the tip, not at the tip, it is near the tip of a chromosome. So in the examples of these acrocentric chromosomes were chromosome 13, 14, 15, 21, 22 and Y chromosome. So between these chromosomes, the translocation can happen. So what happens here is actually a break is going to happen at one end of the near the centromere of both the chromosomes. So here the what happens is this part of the chromosome is going to join with this chromosome, forming a smaller chromosome here, which is going to be lost again, while this part of the chromosome is going to join together and forming the longer arm. Okay, so like in isochromosome, the smaller one is going to be of no use, it is going to be lost, but the larger one, which is having the 2 arms, is going to form the genetic material here. So both isochromosome and Robertsonian translocations are more or less like similar, but the pathogenesis is different. In isochromosome, you are going to have a transverse plane of division rather than a longitudinal division, while in Robertsonian translocation, it is going to happen in acrocentric chromosome, where the break is going to happen around the centromere. Okay. So this Robertsonian translocation is important in the sense it is going to form the pathogenesis in Down syndrome. So Down syndrome, the most common cause is, we all know, it is trisomy 21. But we have two other pathogenic mechanisms in Down syndrome. The second one will be the Robertsonian translocation, which happens between the chromosome translocation 14, 21. Okay. So 21 was the normal thing, right? Trisomy 21. So along with that, the acrocentric chromosome 14 is going to be translocated. So this is going to result in 4% of pathogenesis of Down syndrome. And the third one will be a mosaic, which is going to result for 1% of the Down syndrome. So that we'll be seeing when we see Down syndrome. Okay. So remember, Robertsonian translocation is involved in the pathogenesis of Down syndrome. Now we had seen about the structural disorders of chromosomes. Now let's see about the numerical disorders. So numerical, I already told, the disorder can be either involving the autosomes or sex chromosomes. So first we'll see about the autosomal chromosome defects. So first one will be the Down syndrome. So Down syndrome, here it is going to be because of trisomy 21. So we, instead of 2 copies of chromosome 21, we are going to have 3 copies of chromosome 21. And here, and while reading Fragile X syndrome itself, I told the most common cause of mental retardation is going to be Down's syndrome. So pathogenesis is basically, the first one will be the trisomy, which is because of meiotic non-disjunction. So meiotic non-disjunction is going to happen. So when the disjunction is not going to have, disjunction is not going to happen properly. So one side it is going to have only 1, while the other part which is going to have 3. So it has not divided properly. So 1 and 3 is going to be, so there. This 1 is going to be lost anyways. So this 3 which has formed is going to be derived. So this 3 is the one which is resulting in the trisomy. Okay. So this non-disjunction usually happens in the ova. Meiotic non-disjunction usually happens in ova, and that is why this is Down syndrome is associated with increased maternal age. Okay. So this is the reason it is going to occur in increased maternal age, and this accounts for 95% of the pathogenesis of Down syndrome. So the rest 4% is going to be contributed by Robertsonian translocation between chromosome 21 and translocation 14, or between chromosome 21 with translocation 22. Okay, with either other acrocentric chromosomes like 14 and 22, this chromosome 21 can have translocation, which is Robertsonian translocation, accounting for 4%. When the rest of the 1% is going to be mosaicism, resulting from mitotic non-disjunction here, resulting in 1% of the pathogenesis. So meiotic non-disjunction is the major cause which is associated with maternal age, while the other 5%, which is because of Robertsonian translocation and mitotic non-disjunction or mosaicism, is not going to be associated with maternal age. Okay. They can twist these questions anyways for in multiple choice questions. Okay. So clinically, how do these Down's baby presents like? The child is going to have mental retardation and classical facies. We call it as mongoloid facies. They are going to have a upper palpebral fissure. So oblique palpebral fissure is going to be there. So the eyes are going to be tilted like this, and that is why they have an appearance like a mongoloid people. Okay. And they'll have a hypoplastic nasal bone. So nasal bridge is going to be flattened. So hypoplastic nasal bone will be present. Then brush field spots in the iris is going to be there. Then tongue is going to be open. The mouth is going to be open because the tongue is going to be big. So they'll have kind of a appearance. Okay, the macroglossia is going to be present, because of which the child is going to have a open mouth. And then they'll have umbilical hernias, duodenal atresias, Hirschsprung's disease, and also they'll have a single palmar crease in the palms. So single palmar crease is usually called as a simian palmar crease. So in simian monkeys, right? So they have that single palmar crease. So like that, the Down's baby is going to have. So all of these features can be given. So we must have all seen the Down's baby. That is not a problem. They usually confuse the questions with the pathogenesis. So complications, the most common hematological abnormality happening in a Down syndrome is going to be transient abnormal myelopoiesis. So this is going to be abnormal myelopoiesis, but it will resolve on its own. So transient abnormal myelopoiesis is the most common hematological abnormality in Down syndrome. But if they ask about most common leukemia in Down syndrome, look at the question properly. Overall, it is going to be acute lymphoid leukemia. Okay, lymphoblastic leukemia, acute lymphoblastic leukemia is the most common leukemia. But in less than 2 years of age group, it is going to be acute myeloid leukemia, M7 subtype. M7 is megakaryocytic, right? So in less than 2 years, it is AML M7, while in overall leukemia is going to be ALL. So they are also prone for having many cardiac defects like endocardial cushion defects, congenital heart disease. Then they'll also have premature Alzheimer's disease. So reason again, we have already discussed in amyloidosis. APP, amyloid precursor protein, is going to be present in chromosome 21. This amyloid precursor protein is going to be cleaved by beta gamma secretase activity in Down syndrome. So, so if it enters into the amyloidogenic pathway, beta gamma secretase activity will be there, which is going to produce A beta, which is the amyloid. So this amyloid is going to aggregate, form oligomers and polymers, and that is the one which is responsible for the disease pathogenesis in Alzheimer's. So since amyloid precursor protein is present on chromosome 21, Down syndrome, which is already trisomy 21, means there is going to be an extra copy of APP. So from that, they are going to develop Alzheimer's disease at a very early age group of less than 40 years itself. Okay. So apart from that, we are going to have duodenal atresia, Hirschsprung's disease, other autoimmune diseases and tumors. Okay. So how do you diagnose this Down syndrome? So prenatally also we can screen for the you can use certain screening tests. We can use triple test and quadruple test. So components of triple test is going to be estriol, alpha fetoprotein and beta HCG. So estriol is going to be decreased, AFP is going to be decreased, and beta HCG is going to be increased in Down syndrome. Now in quadruple test, it is going to be the triple test. Along with that, they are going to measure inhibin. Inhibin is going to be increased. Okay. So confirmatory test is karyotyping, the image of which we had already seen. So in the chromosome 21, you can see 3 copies. Then we'll see other trisomies, which is Patot syndrome and Edwards syndrome. So Patot syndrome, again the karyotype we already saw. This was trisomy 13. Patot is trisomy 13. Edwards syndrome is trisomy 18. So 18 is E, right? So E for E. So both of this again is going to be resulting from the meiotic non-disjunction happening in the ova only. So like Down syndrome, this is the pathogenesis mainly. So here again it is associated with the maternal age, increased maternal age. Then clinically, if you see, these patients are going to have rocker bottom feet. So rocker bottom is nothing but, you must have seen elderly people who are rocking on a chair like this, which is having a base like this, right? They'll be doing like this. So that kind of a feet will be present for these kids. So it is called as rocker bottom feet. Apart from that, renal defects are going to be present. Congenital heart defects are going to be present. Mental retardation is going to be present. So in renal defects, it is going to be horseshoe kidney. That is, the lower pole of both the kidneys is going to be attached like this, crossing the midline and attached like this, appearing like a horseshoe. So this is what we see in Edwards syndrome, horseshoe kidney in Edwards syndrome. Apart from that, these are the common features. So apart from that, what are the different features which we see, how to differentiate between Patot and Edwards? In Patot syndrome, the child is going to have a microcephaly, a smaller head with a smaller eye, so microphthalmia. Along with that, multiple fingers, so polydactyly, cleft lip and palate, and coloboma. Okay, coloboma is nothing but vertical slit kind of thing which are going to see in the eyes. So keyhole like deformity will be there like this in the iris. So these are colobomas. So microcephaly along with cleft palate and cleft lip, then polydactyly, and then microphthalmia along with this coloboma is classical features of peto. While in Edward, the kid is going to have a prominent occiput. The occiput is going to be elongated like this, and here they'll have micrognathia. The jaw is going to be small. So micrognathia along with overlapping fingers. Okay, so the kid image based question they can give, the fingers will be overlapped like this, and the hip abduction will be limited. So normally if you see the kid usually tends to sit like this, right? But in this the kid cannot sit like that. The picture will be given like this. Okay, so in Edward it is limited hip abduction along with the prominent occiput, overlapping fingers and micrognathia. So if they ask what is the most common trisomy, don't just jump into Down syndrome. Okay, trisomy 16 is the most common trisomy, but it is not compatible with life and it gets aborted. Okay, but as such most common trisomy is trisomy 16. And look at the question carefully. If they ask most common trisomy which is compatible with life, then it is Down syndrome. Okay, that is trisomy 21. Trisomy 22 is also there, which is called as the cat-eye syndrome. Cat-eye syndrome because in trisomy 22, they are going to have multiple vertical colobomas. So this keyhole-like deformity is there, right? So that is going to give the appearance as a cat's eye. So multiple vertical colobomas will be present in this trisomy 22. That is why given the other name as cat-eye syndrome. So now we are seeing about the autosomal numerical disorders. Let's move on to the sex chromosomal disorders. So under sex chromosomal disorder, first is the Klinefelter's syndrome. So the genotype we have already discussed, it is going to be extra X chromosome, either 1X or 2X. So if it is a 1X, which is extra, it is going to be XXY or 48 triple XY, right? So don't confuse it. You should not tick the answer as 46 XXY or 46 triple XY. It is 47 double XY or 48 triple XY. Okay, here the extra chromosome, the extra X which has been derived, right? So extra X chromosome is usually maternally derived rather than paternally. Okay. Even in trisomy 21, that is Downs, Peto and Edward, the extra chromosome 21 or 13 or 18 was derived from the maternal origin. Here in Klinefelter's, it can be either paternal or maternal, but more often it is a maternal chromosome from which this X chromosome is derived. So here again, the meiotic non-disjunction is the major pathogenesis, like in other trisomies. So clinically, they'll give the history of a very tall guy with long legs, like a morphonoid habitus basically. So a tall guy with long legs. Along with that, they'll have a history of hypogonadism, atrophic testis and small penis, and secondary sexual characters wouldn't have developed in these patients. And then they'll have mental retardation as well. So congenital heart disease, usually it is going to be mitral valve prolapse like in a morphonoid again. So morphonoid is also going to have mitral valve prolapse with a morphonoid tall habitus, but they'll have arachnodactyly in Marfan syndrome along with hyperflexible joints. But here in Klinefelter's, you are going to have mental retardation with hypogonadism, that is small atrophic testis and penis, with lack of secondary sexual characters. As such, these Klinefelter syndrome are going to be having an increased risk of certain cancers. First one will be a extragonadal germ cell tumors. So germ cell tumors we normally see in the testis and ovary, right? So here it is going to be extragonadal. So extragonadal, as such, it is seen in mediastinum. So in mediastinum, especially, it is going to be teratoma. So mediastinal teratomas are common. The increased risk of developing mediastinal teratomas, which is extragonadal germ cell tumor. And apart from that, they are also at an increased risk of developing breast cancer. Okay, male breast cancer. So these two are important. Again, these cancers have an increased risk in Klinefelter syndrome. So if you will check for the hormone levels, so testis is atrophic, right? So testosterone levels will be down. And in order to stimulate, the follicular stimulating hormone, FSH, will be elevated. And estradiol is also going to be elevated. So moving on to the second sex chromosomal disorder, it is going to be Turner syndrome. So Turner's, already I mentioned, the genotype is 45XO. This is because of deletion of the second X, or it could be ring chromosome. So ring chromosome, both X are actually present. So it is going to be 46 only. So one X is normal, the other X is the ring X. Okay. So this ring X is going to be useless basically. So clinical features, the Turner syndrome patients usually they present with primary amenorrhea. Okay, so they must have not attained the puberty, so and they'll have hypogonadism. Along with that, they'll have absence of secondary sexual characters at puberty. So because of this primary amenorrhea, the ovaries are going to appear just like a streak. Okay, just like a streak. So they are called as streak ovaries. And then the phenotype of Turner syndrome is they'll be of short stature with a low hairline. The hairline would have reached up till here. Low hairline will be there along with webbing of the neck. So a very small neck with attachment of the neck web to the shoulder directly like this. So webbing of the neck will be there. Then they'll have a very broad chest with widely spaced nipples. Then coarctation of aorta along with bicuspid aortic valve. So heart defects are going to be present. Then IQ is usually normal. So far we had seen all trisomies, Downs, Pato, Edward, then Klinefelters. All of this had mental retardation. But in Turner's, it is going to be normal IQ or only slightly decreased IQ. Okay. So basically, they'll notice this disease mostly during when they don't attain puberty. So primary amenorrhea is going to be there. So there is something called as Noonan syndrome, which is exactly the male counterpart of this Turner's. So if Turner's is XO, right? So it is going to be female. So male counterpart of Turner's syndrome is going to be called as Noonan syndrome. And here the chromosome 12 is going to be defective.